and welcome to the Mama Doc Baby Doc podcast. We're so glad you joined us for another episode. I am Rachel. I'm a pediatrician, and I'm here with my mother, Renda, who is an OBGYN. Hey, Mom.
Hi, Rachel. So it's really great to be back for another episode. Thank you to all of our listeners. Every week our number of listeners is growing, and we're just so thankful for that. So
Yeah,
if you are listening and you enjoy our podcast, please give us a rating and review. That helps other people find us.
yeah, yay. Also, tell all of your friends to give us a listen. And if you have any specific topics you want us to cover, let us know. Email us, send us a DM on social media, or if you know us, text us.
Right. And so today's episode is going to be all about nausea and vomiting during pregnancy. And that can be the absolute worst.
Worse.
But I'm going to help you get through it. And with the information that's in today's episode, you'll have tips that you can use to help get through it.
Yeah, that is one thing I think most women dread when they get pregnant is nausea. And it's like all the things you see in the movies, like that's
Right.
how they knew they were pregnant. They started throwing up
Right.
and then anytime I get sick at work, like if I'm like, oh, my stomach doesn't feel good, everyone's like, are you pregnant? No.
Ugh.
So, Mom, how common is nausea and vomiting during pregnancy? Because it seems like everyone has it.
Yeah, well, it affects anywhere from 50 to 80% of pregnant women. So the majority of pregnant women.
Yeah, that's a lot. I mean, and chances are, if you're listening, you can probably relate. Most people may have experienced this or be suffering from morning sickness or nausea and vomiting in pregnancy right now. And I remember how bad it was for me. Like, I didn't have it horrible, but there was um, a period of like a couple months where I couldn't even smell meat cooking, or I would just want to die inside. But I think today we're going to chat and help you understand what you can expect with the nausea and vomiting during pregnancy and kind of give you some options that will hopefully help.
Right. Yeah. Today, we're going to talk about what causes nausea and vomiting in pregnancy, what to expect in terms of the course of the nausea and vomiting. And then we're going to review some treatment options, including non medication options and also the different medications that are out there. And then I'm going to point to one option that's become a little bit more popular, but actually is not recommended and may not be entirely safe. So we're going to talk about that one too. Yay.
So, first thing I want to say to get this out of the way, because sometimes people get really worried about this. If you don't have nausea and vomiting, that does not mean that anything is wrong with your baby, your pregnancy.
That's absolutely right. At least 20% of women will not have any nausea or vomiting, and it can be up to as high as 50% who don't get sick in pregnancy. So if you never have nausea and vomiting, it does not mean that anything is wrong.
It
Okay.
just means we're all jealous of you.
Yeah, right.
You might get beat up by other pregnant women.
Right.
Okay, so tell us, Mom, what causes nausea and vomiting in pregnancy?
Actually, we don't know what causes nausea and vomiting in pregnancy. There are a lot of different theories out there, and many different factors play a role. But we do think that it's primarily related to the sudden rise in hormones, particularly HCG, which is human chorionic gonadotropin. That's the pregnancy hormone. It's unique to pregnancy, and pregnancies that have a higher HCG level are often going to have more nausea and vomiting associated with them. And that would include things like a twin or triplet pregnancy or something called a molar pregnancies. Now, other hormones also go up in pregnancy, like estrogen and progesterone levels. Estrogen can also be associated with nausea, and that's why taking birth control pills sometimes makes some women feel nauseated, right?
Yeah. I've also heard there's a genetic component. Like some of my friends will say, oh, my mom was horribly nauseous, so I'm going to be nauseous when I get pregnant. Is that true?
Yeah, so daughters and sisters of women who've had hyperemesis gravidarum, which is extremely severe nausea and vomiting in pregnancy, those women are much more likely to have the same problem. So we think that there is a genetic component. It can also be related to a slower gastric motility. And what I mean by that is progesterone, which is one of the other hormones that goes up in pregnancy that um, slows down your muscles. So it's a smooth muscle relaxant. So it may make things like your stomach empty slower. So things stay in your stomach longer. And then that can contribute to more nausea and vomiting during pregnancy.
Yeah. You said women who have twins are at an increased risk of having more severe nausea and vomiting. But what about if the baby is a boy or a girl? Does that make a difference?
Ooh, yeah, actually it does. If you are carrying a girl, then you are at increased risk, and we don't really know why. Now, this doesn't mean that all boy moms are off the hook. They can
Yeah.
definitely still have nausea associated with pregnancy. It's just more frequent and tends to be a little bit more intense with a girl
Hmm,
baby.
interesting.
Also, if you have a history of motion sickness, if you're somebody who gets seasick or you get migraines, if you have a history of nausea and vomiting in a previous pregnancy, then naturally that's also going to increase your risk of having it in another pregnancy. If you have it in another pregnancy, approximately two-thirds of women who described their vomiting as severe in one pregnancy did, unfortunately, have similar symptoms in the next pregnancy. And about half of women who described their symptoms as mild found that their symptoms actually got a little bit worse in the next pregnancy.
So, not the best news, but can you give us some information about what the pregnancy course may be like? When can we expect morning sickness to get better or to go away?
Yeah. So I don't actually call it morning sickness anymore because it's not true. It's
Yeah.
called morning sickness because it tends to be worse in the morning. However, most women know that nausea and vomiting of pregnancy can occur any time of the day or night.
Yes.
It's not confined to the morning, right?
Yeah. And sometimes patients wonder why they're throwing up in the afternoon if it's morning sickness. I think morning sickness is a misnomer. It just means that
Yeah.
it tends to be worse in the morning, but it can really happen all day.
Right. And as far as how long it happens, it generally starts early and it ends fairly early. So it almost always begins around 5 or 6 weeks of gestation. So, really, pretty early in pregnancy. You know, the first time you miss your period, that's 4 weeks. So,
Mhm.
really, it generally starts just a week or two after you notice your period is late. The nausea and vomiting then tend to peak at about 9 weeks. And for most women, it will have completely resolved by around 16 weeks.
That's great news. So there's hope. It won't last forever. There's a light at the end of the tunnel.
Right, right. But for about 15% of women, unfortunately, it will continue until the third trimester. And for about 5% of women, it continues all the way up until birth.
Yikes.
And I see, unfortunately, that sometimes doctors don't recognize that this is a possibility that people can have that continued nausea and vomiting all the way up until ready to give birth. I
Yeah,
think we're getting a little bit better at that, but it definitely can last into the third trimester for a small percentage of people, and it can last all the way up until birth.
I can't imagine having all the nausea and vomiting on top of all the third trimester symptoms too. That sounds just
Right,
horrible.
right.
But you talked about hyperemesis gravidarum, and that's extreme nausea and vomiting. How do you make that diagnosis? Like, where's the cutoff to extreme?
Yeah. So there's not one really accepted definition, but most describe it as a persistent nausea or persistent vomiting that results in electrolyte changes. So many of these patients can't even keep down liquids and they can't keep down solids. So there's usually some weight loss accompanied with it, and their normal daily activities are definitely affected. I mean, they can't even go to work, right?
Yeah, it's hard to function or like even get out of bed when your nausea and vomiting is so extreme.
Right. And with hyperemesis, it may even require hospitalization for a short period of time. In some patients, it requires home IV fluids. I mean, you can actually get medications on a pump at home in extreme cases. And in very, very extreme cases, we can give IV nutrition, which is like a parenteral nutrition through an IV. In rare instances, that may become necessary, but that is very, very rare.
Oh
Usually
my
it's just
gosh.
fluids and medication that's required.
Yeah, I can't imagine. So for many women, that nausea and vomiting in pregnancy can be extremely annoying and actually can be really miserable, honestly. And I've heard of it even causing depression. But it's not physically harmful to the mom or baby unless it's an extreme case where malnutrition is a problem.
Yeah, that's absolutely right. For most women, the vast majority of pregnant women with nausea and vomiting, there's no physical harm to mom or baby. I mean, it's just miserable to be having that nausea and vomiting all the
Yeah.
time. And actually, there's pretty strong evidence that women that have nausea and vomiting in pregnancy actually have a lower miscarriage rate than women who don't.
Interesting. I'm not sure if that makes you feel better. Maybe it does, maybe it doesn't. But again, it's annoying, but not physically harmful. So,
Right. Now, as far as the clinical evaluation, if someone is having nausea and vomiting, we look for things to make sure that it's not severe. So we do this evaluation in people who have persistent nausea and vomiting, particularly the vomiting. Nausea alone, we don't typically do any blood work because nausea alone doesn't cause issues. It's going to be the persistent vomiting. So if I have a patient with persistent vomiting, I'm going to check their urine to see if they have ketones. Ketones are a substance that are produced in the urine when you're dehydrated. So if my patient has ketones in their urine, that's evidence of being dehydrated. I'm also going to check their electrolytes like potassium and sodium, because when you're vomiting a lot, those can get really low and sometimes we need to replace them. I'm also going to check their liver function and check their kidney function because being very dehydrated can affect those as well. And I'm going to check their thyroid because sometimes abnormalities in the thyroid can actually cause extreme nausea and vomiting. So I want to rule that out as an underlying cause. Now, if patients are having extreme nausea and vomiting and they have not already had an ultrasound, then I'm definitely going to want to do an ultrasound to assess to see if they have multiples like twins or triplets, and also to see if there could be something like a gestational trophoblastic disease or molar pregnancy, which is an abnormal condition of pregnancy. Now, usually a molar pregnancy results from a sperm fertilizing an empty egg or two sperm fertilizing a normal egg. And both conditions can cause very high HCG levels. And I mean, if you have multiples or if you have gestational trophoblastic disease, both of those can cause high levels of HCG. And that may be why you have nausea and vomiting. Fortunately, gestational trophoblastic disease is not very common. It is not a normal pregnancy, and it will not result in a live baby. It always results in miscarriage or a D&C to evacuate the contents of the uterus. Again, the baby never really develops, so it's not a normal pregnancy.
yeah. So you're going to do this evaluation to make sure it's a normal pregnancy and that there's
Right?
not an underlying thyroid disorder or some other problem. I know that the goal of treatment is to really help the patient feel better, help improve mom's quality of life, and help reduce symptoms so she can feel better. And if it's severe, and there are those electrolyte disturbances like you talked about when we have, very low sodium or potassium is out of whack, then we want to correct that, rehydrate and replace any of the electrolytes that are too low. We want to make sure that mom, isn't dehydrated, make sure that her potassium, sodium, and other electrolytes are okay and in the right spot. And we want to prevent it from getting to those severe states where the pregnant patient has lots of vomiting that can cause weight loss or vitamin deficiencies or things like that. Is that right?
Right. And it's really about feeling better, helping mom to feel better and helping to prevent the dehydration and the electrolyte imbalances.
Okay, so now let's talk about treatment then. What can a pregnant woman do if she's starting to have these symptoms?
So let's start with things that don't require medications. One thing that's helpful is if you're taking a multivitamin at the time of getting pregnant. There have been several medical studies that have found that women are less likely to need treatment for vomiting if they're on a vitamin when they get pregnant, when they conceive. So taking a prenatal vitamin for at least a month before you get pregnant may help to prevent nausea and vomiting from even developing. So everybody of reproductive age who's thinking about getting pregnant, you really should be taking your prenatal vitamins, ideally before you get pregnant, right?
Yeah. And even if you're not thinking about getting pregnant, if you're of reproductive age and doing things that could possibly get you pregnant, please take your multivitamin with folic acid, please.
Yeah.
Yeah, the folic acid really helps with neural tube defects. We talked about this in another episode, but that's another reason why taking prenatal vitamins before pregnancy is so important. Like I said, if you are planning to or not planning to, it's not fun when you have an unplanned pregnancy, but it's even less fun when you have an unplanned pregnancy and your child has issues like neural tube defects. So just take your prenatals. But if you're in this situation when you're already pregnant, like you already have the nausea and vomiting, you're already pregnant, there's still plenty of things you can do, right? So talk about those.
Of course, yeah. Right. So I recommend starting with dietary changes. And to be honest, there's not a ton of scientific evidence necessarily about how dietary changes can affect nausea and vomiting in pregnancy. But in experience and in practice, it definitely can help. So it's one of those things where it hasn't really been studied, but we just know from experience that it does help. So first of all, you want to eat before or as soon as you start to feel hungry, so you can avoid having an empty stomach. Having an empty stomach can aggravate the nausea, and we think that's due to excess acid production. Now, number two, instead of big meals, you're going to want to eat smaller meals every few hours, and also eat slowly. That helps to prevent your stomach from feeling both extremes, feeling either empty or getting too full at any given time, because both of those, either feeling empty or feeling full, can really aggravate the nausea. You also don't want to skip meals for that reason as well, about not feeling that empty sensation. The next thing, avoid spicy foods, avoid fatty foods. There has been a small study that did show that eating protein is better at reducing nausea and vomiting in pregnancy. So stick with those protein-rich foods like almonds, boiled eggs, Greek yogurt, lean chicken, lean turkey. You also want to eliminate things like coffee, things that, again, are really spicy or have a lot of odor or smell, because sometimes that can trigger nausea. You don't want to eat things that are very acidic. You don't want to eat really super sweet foods. And just, again, work on those protein dominant foods, things that are more bland, low fat, dry, and actually salty. A little bit salty can help too.
Yeah. So things like nuts, pretzels, crackers, cereal, toast, rice. It's a very boring diet, unfortunately. But, if it helps you feel better, remember, it's only going to be for short term.
Right. You're not going to have to eat like that for your entire pregnancy, but that bland diet can really help you feel better. Also, sucking on peppermint candies can reduce nausea after eating. And there's going to be some trial and error, in figuring out what foods work best for you. You really just have to, and this is going to sound obvious, right? But you really have to determine the things that you can eat and just stick to eating that. And it may be foods that you previously ate without any problems may bother you now. And that can be really frustrating, I know.
So you're going to, again, have some trial and error. Yeah, like I said, I had horrible time smelling meat. And I know you were always telling me, eat protein. And I could not stand. Anytime John would cook chicken or, beef, we went to a couple Mexican restaurants actually during that time. And I could not eat Mexican food for months, even after I delivered JJ. I was like, I can't, my stomach, just thinking about it made me feel awful. But what I really did end up liking, which is funny because I usually hate it, is like a big breakfast with eggs, fried eggs and bacon and toast. For some reason, every day, that's kind of what I wanted. So, It is. It's just trial and error and eating things that make you feel okay.
Right. So I think everyone just has to determine what they can eat and then eat that.
Yeah.
Also, you may want to wait a little bit after eating to drink. And that's going to, again, minimize that feeling of being too full that can aggravate the nausea. And then even cold drinks or frozen things like popsicles can work to hydrate you a little bit better. And some people find that sour drinks also help. Sports drinks like Gatorade can help as well. They have electrolytes. And also, using a straw so that you're drinking a little bit more slowly can help too. And then avoid any triggers, any food, any drink that may cause you to have the nausea and vomiting. You might find certain smells or motions might make you feel sick or send you over the edge. And we don't know exactly why some things trigger it. And some things may trigger it. Are being in a stuffy room, certain smells like perfumes, chemicals, smoke, certain foods, cooking may even trigger that nausea and vomiting. Sometimes it's heat, humidity, and even sometimes visual or physical motion like flickering lights can trigger it. So just do your best to avoid the triggers.
Yeah. I also know that like nausea from other things like a stomach bug or something, you could drink ginger ale and it helps. I'm sure this would
Right.
help with pregnancy too.
That's right. Ginger has been shown to improve nausea. It hasn't been shown so much to improve vomiting, but it has been shown to help with nausea. So you can use ginger lollipops, ginger chews, ginger tea. They even make ginger capsules that are available over the counter. And of course, ginger ale is fine either with or without bubbles. For some people, the carbonation helps. For others, the carbonation makes it worse. So you can either drink your ginger ale straight, or if the bubbles bother you, just open it and let it go flat before you drink it.
Flat ginger ale, yum. Okay, so what are some other things women can do to help the nausea other than changing their diet?
Yeah. So, in terms of things that are not medications, things like acupuncture or acupressure can actually help. They make acupressure wristbands that are worn on the wrist at the P6 point, and that can help with nausea and vomiting in pregnancy. Results of a lot of different research studies are conflicting, but it's so low risk and it's reasonable to give it a try. And the acupressure point is located on the inner forearm. You can locate it by placing 3 fingers of your opposite hand, so your index, middle, and ring finger, just below the crease in your wrist on the inside of your forearm. And the P6 point is located right between the 2 tendons. You feel it in the center of your wrist. So you can apply gentle pressure with your thumb and forefinger in that spot just for a couple minutes, maybe rub it in a circular motion or apply steady pressure. Or you can get one of those acupressure wristbands. You can order it on Amazon even. Yeah.
I've seen those for motion sickness. Yeah. I think they're called C-bands. Yeah. They might not be called acupressure if you go to look for it. Google motion sickness bands. They're cheap, easily available, and they're designed to target that P6 point. They provide constant, gentle pressure. It's just a band that goes around your arm to help alleviate the nausea.
Right. Okay. So now let's move into the different medication options. It is fairly common that those dietary changes, the ginger, the acupressure, sometimes they're just not enough, and people require medication to help. Now, the first line of medication treatment is going to be vitamin B6, which is pyridoxine. It can be taken alone, or it can be taken in combination with an antihistamine called doxalamine. Diclegis is a prescription medication version of that combination of B6 and doxalamine. However, you can get vitamin B6 and doxalamine over the counter. B6 is just that. It's vitamin B6. And Unisom, the sleep aid Unisom that's over the counter, is doxalamine. The prescription Diclegis tends to be a lot more expensive. So I usually just have my patients pick up B6 and Unisom over the counter.
Yeah, and definitely check with your doctor, for recommendations on how to take it. I know that when you recommended it for me when I was pregnant, I took a dose while I was out and about and was immediately exhausted. Like 15, 20 minutes after I took it, couldn't hold my eyes open, and I was driving home. So I think generally it's a good idea to start with a dose at bedtime, and then add it during the day, if you need it. Just see how it's going to affect you. Now, if the symptoms persist beyond the B6 and doxalamine, then you add other medications, right?
Absolutely. Yeah. Generally, we're going to add on top of things that the patient is already doing. The way we make that decision is if something is helping a little bit, then keep taking it. So even if the nausea and vomiting isn't completely gone, but that medicine is helping some, then we continue it and then add something else. However, if it's not working at all, then you can just stop the medication altogether, and you want to try a new medication for at least a week to see if it helps. You have to give it some time to see if it's going to be effective.
So you're saying you need to try the medication for at least a week to see if it's going to help. So if you start with the B6 and doxalamine, where do you go next? Like, what would you add?
Yeah. So the next thing to add is an antihistamine. And I usually start with diphenhydramine, which is the active ingredient in Benadryl. So you can try Benadryl, which is also over the counter. Again, you can add it at night so that you don't fall asleep during the day. And, taking it at bedtime, the goal is that you don't wake up sick in the morning. You do have to be careful, though, when you take both Benadryl and Unisom at the same time, because that's going to make you extra sleepy. And you might be a little bit sleepy even in the morning when it's time to wake up.
Yeah, you can also try Dramamine too. That's the motion sickness medication.
Right.
If it's another antihistamine, you want to get the sleepy Dramamine, not the non-sleepy Dramamine.
Right.
But Dramamine's the brand name. It's just another antihistamine. It's often used for motion sickness, but I know that it can be helpful for some patients who have nausea.
Right. Absolutely. You can try Dramamine as well. But again, be careful taking Unisom and Dramamine together. You're going to get a little bit sleepy and you don't want to get overly sleepy.
Yeah.
All right. So you can try those antihistamines. And next, after that, in kind of a stepwise fashion, I typically would then add Phenergan or promethazine. And promethazine is considered safe for moms and babies. It's been used for decades and decades to treat nausea and vomiting in pregnancy. But it too can have some fairly significant sedation as a side effect. So you have to be careful with Phenergan and letting your body get used to it or timing it so that you take it more at nighttime. And the benefit of Phenergan is that it can be given orally or rectally in the form of a suppository. So for those women that are having intractable vomiting and can't keep the pills down, they could use a suppository. I also sometimes try Compazine. Prochlorperazine is the generic for that. Compazine may have mild side effects like drowsiness, fuzziness, or headaches as well. And then Reglan, that's the next thing I try, which is a motility agent. It helps move things through your GI system. Now, Reglan is a prescription and it can have some maternal side effects with long-term use. In rare cases, it can cause movement disorders in women who take it, but it really does not appear to increase any risk for your baby. So that's not one we commonly use for a long time, but it's not something you can take for like the whole duration of your pregnancy, but you can do it for a short period of time and it's pretty safe.
And, another prescription medication, one that I used frequently, is called Zofran. Zofran is ondansetron. And the benefit of Zofran is that it doesn't cause sedation, which is really nice. You could take it and be at work, do things that you need to.
So Zofran is great. However, it does have some side effects like headache and fatigue. And sometimes constipation can be terrible for some women with Zofran. So you may need to take a stool softener to help if you have constipation while taking Zofran.
I think there was some concern about the risk of Zofran causing small increased risk of congenital anomalies too, including cleft lip and palate and heart malformations. The risk is, more pronounced in the first trimester. So, chat with your OBGYN, or if you have a pediatrician already, chat with them kind of about the risks and benefits of taking Zofran.
Right, right. And just to give everybody an idea, it is a very, very, very small increased risk. So let's say if you are not taking Zofran, there are about 10 cases per 100,000 births of cleft lip and palate. If you are taking Zofran, that risk goes up to 12 cases per 10,000 live births. So there's a tiny increased risk of cleft lip and palate, and similar risk for heart malformations as well. About 10 cases per 1,000 live births of heart malformations, or 12 cases per 1,000 with Zofran. So there's a tiny bit of an increased risk. And that risk, again, is most pronounced in the first trimester. So the current recommendation from ACOG, the American College of Obstetrics and Gynecologists, is to avoid Zofran at less than 10 weeks of pregnancy. However, if nothing else is working and someone needs Zofran under 10 weeks, then I just have a discussion with them about the risks and benefits.
Yeah, but it's, I mean, either way, it's not usually the first line medication for nausea and vomiting in pregnancy. Like we've talked about a lot of things other than Zofran.
Correct, correct. But now, in addition to those medicines, the B6 and Unisom, Phenergan, Compazine, Reglan, and Zofran, you may also need an acid-reducing medication, because if you're having acid reflux, that can make the nausea and vomiting even worse. So I will often add Tums or Pepcid, and those can be helpful as well to reduce the amount of acid. Now, one thing that's really important to remember is when you're taking these medications, you really want to take them on a regular, scheduled basis. At a minimum, you want to take them as soon as you experience a hint of symptoms. Just do not wait until it gets really, really bad. Don't try to hold off and not take it and wait until it gets really bad, because then it's very difficult to try and catch up. So you want to try and get ahead and stay ahead of the nausea and vomiting by staying on the medication on a regular basis. So, how do you know when to stop the medication? So what you do is you just kind of slowly back down, go longer and longer between taking the medications. Just kind of space it out until you figure out that you don't need to take the medication anymore. But don't wait until it gets really bad, because then you're trying to play catch up, and that's not a good spot to be in. Now, the last thing I want to say about when to go to the hospital, if you have severe nausea and vomiting in pregnancy, when you need to go to the hospital is when you cannot keep anything down, no food, no liquids for more than 12 hours. At that point, you're at increased risk for having dehydration. At that point, you're probably going to need some IV fluids. If you've been unable to keep anything down for 12 hours, then you're very likely to be starting to feel really bad. If you're dizzy when you stand up, if your heart is racing, if you're not using the bathroom as much, those are some reasons to go to the hospital and get checked out. Now, hopefully, what we often can do is give you some IV fluids, give you some IV anti-nausea medicine and medicine to help with vomiting. And then we get you tuned up and you can go home on oral medicines and feel much better. So the idea is to keep patients out of the hospital if we can. However, if that doesn't work, if you don't feel better after the IV medications, some women do need to be admitted to the hospital for ongoing treatment for a few days in order to get their electrolytes back into balance and in order to find a combination of medicines that work so that you can then go home with a regimen that helps you feel better. And if that's not working, because this regimen usually works great, but in rare instances, the last medicine that we add in the case of severe hyperemesis is a short course of steroids. So generally, we're going to use steroids after 10 weeks because it can increase the risk, again, of cleft palate. It can also increase blood sugar, so we have to be mindful of that, especially in women with diabetes or a tendency toward high blood sugar. But a short course of steroids, if you need to be hospitalized, may be really helpful. Also, gabapentin, interestingly, can really help with nausea and vomiting in pregnancy. So, we have lots of options, lots of things that we can try to help with the nausea and vomiting. It's just a matter of trying these different things, adding different medications, and figuring out what works, because every patient is going to be a little bit different. And physicians do really take this seriously, because dehydration can be a real problem if we don't get the nausea and vomiting under control. Now, the last thing I want to say is something that a lot of women are using and find helpful, but that has not really been studied enough to know that it's safe. and that is cannabis or marijuana, weed. It's legal here in Alaska. It's legal in Colorado, where Rachel lives, and the use of it has increased a lot during pregnancy. There are so many more pregnant women self-reporting that they're using it to alleviate the symptoms of nausea and vomiting in pregnancy. And although it may work, it is not something that physicians currently recommend because we don't have the data to be able to tell patients that it's safe in pregnancy. We don't know the potential risks. I mean, outside of pregnancy, like for people who are getting chemotherapy treatment, for instance, it is often used and considered safe. But since we don't have the data to back up use during pregnancy, we just don't typically recommend it. Now, it's also associated with quite a few risks. Low birth weight, premature birth, a smaller head circumference. Those are all risks of using marijuana during pregnancy. So marijuana can affect the brain development of a developing fetus. It can lead to increased risk of behavioral problems, ADHD, learning disabilities. There's a small increased risk of stillbirth or issues with the placenta. So I always tell my patients it's really best to avoid cannabis during pregnancy, even though it really can be effective with the nausea and vomiting. Now, I have had some patients who actually suffer from cannabinoid hyperemesis syndrome, which is nausea and vomiting caused by the long-term use of cannabis. So long-term use of marijuana can result in this paradoxical rebound nausea and vomiting. And I've actually had to hospitalize patients just for this condition. So it definitely can be pretty severe. Okay, so just to recap, nausea and vomiting in pregnancy we think is caused by an increase in the hormones, particularly HCG and estrogen. For most people, it starts really early in pregnancy, around 5 to 6 weeks, and it also ends early by about 16 weeks. But there's a small percentage of women in which it's going to last into the 3rd trimester and even for some up until delivery. As far as treatment options, you can start with dietary changes, acupressure, and ginger. And then if you need medication, you can start with vitamin B6 and pyridoxine and doxalamine, which is Unisom, and then add Phenergan, Compazine, Reglan, and Zofran. In extreme cases, steroids or gabapentin might be helpful. We do not recommend using cannabis in pregnancy to treat nausea and vomiting. Okay, so if a patient has persistent nausea and vomiting and can't keep anything down for a period of 12 hours, then it's really important to go to the hospital and get checked. If you cannot keep fluids down, even if solids come back up, as long as you can stay well hydrated, then you generally don't need to go to the hospital. So as long as you can keep down the fluids, you're good. But once you're vomiting liquids for 12 hours or more, you really need to go in. But if you're able to just keep down the fluids, but not solids, I would recommend making an appointment with your doctor to be seen and get your medications adjusted. It's really just when you're at risk for dehydration that you need to go to the hospital. Okay, so there you have it. That is all for today's episode. Thank you for joining us, and please share this podcast with a friend. Remember to subscribe and give us a review. We'd greatly appreciate that. And check back next week for another episode of Mama Doc, Baby Doc. Bye for now.